In previous video, we have discussed about pain pathway and its central connections. Now in today's lecture, we will discuss about pain perception and its modulation. I will explain the pain perception in terms of biopsychosocial model, and then we will discuss how the pain is modulated in accordance with the pain gate theory, which is first proposed by Melzack and Wall in 1965. And then later on revised to include many advanced concepts of pain modulation like central analgesia. So let's begin with concept of pain perception. Historically, the concept of pain, even chronic pain, depended on a linear relationship between identifiable organic pathology and patient-reported symptoms. Thus, the amount of pain was expected to be perfectly proportional to the amount of tissue damage which is causing the pain. But indeed, this is not the case in reality. Imagine a small child playing with his friends and he accidentally falls down. Immediately after fall, he will first look around, and if he sees his mother or father watching him, he will start crying loudly, as if he got a very bad injury, even though it is just a small bruise. But in another scenario, if he does not find any of his parents around, he will not cry and immediately gets up and starts playing with his friends again, as if nothing has happened, even though he might have some bleeding from the wound. Why this difference in pain perception among two different scenarios? To understand this, we must understand that pain is not just a simple expression of tissue damage and is not always proportional to tissue damage, but it is altered by multiple factors which can be explained by biopsychosocial model of pain perception. So the biopsychosocial model, it views the pain as an interaction between the biological, psychological and socio-cultural variables. So biological variables, they include age, gender, obesity, duration of pain, previous pain episodes, site of pain, type of injury, etc. etc. So let's elaborate this a bit. So a small child will feel a lot of pain with a simple injection, but that same injection is not that much painful for an adult. So that's how the perception of pain varies with age. Same thing with gender. Males don't express the pain easily and have more tolerance compared to the females. Similarly, previous experience of the pain alters its perception. Imagine a professional boxer. Here, in the case of a boxer, it is obvious that during his career, he must have received many punches from his opponents and must have got used to those minor injuries from punches, and thus he will not feel much pain when he gets hit. But if we receive the same kind of punch, we may not get up from the bed for a whole day due to the severe pain. Another example is pain spasm pain cycle. Imagine a person got disc bulge with resultant severe low back pain, which indeed leads to spasm of paraspinal muscles, which further aggravates the pain, which leads to more severe spasm, and the cycle continues and perception of pain alters. Next, come to psychological variable. It includes fear, anxiety, depression, surrounding environment, etc. So imagine a person having fear of injection. For him, the same injection will be much painful than the one who is not afraid of it. Similarly, the depression increases the intensity of pain perception. They feel any particular injury more painful compared to the normal individual. Surrounding environment also affects the pain perception in similar manner. Imagine a soldier in battlefield who gets very severe bullet shot injuries or may have lost his hand, he will not feel pain as long as he is busy in battle and feel that pain as soon as he returns to the camp. Another example is a small child playing with his friends who accidentally falls down and starts crying if he sees that his parents are watching him. Whereas if he don't find anyone watching him, he will get up and starts playing with his friends again as if nothing has happened. Now let's come to social variables. They include variables like lower socioeconomic status, lower education, living alone, poor coping strategies, less social support, etc. etc. So imagine a person who sustained a minor injury is not having enough money or resources to go to a doctor for dressing. He may ultimately end up with wound getting infected and becoming more painful and more chronic, which further increases the pain. Another example may be social isolation. A person living alone will feel minor injuries more painful compared to those who are living with family or friends. Another example of social variable affecting the pain perception is a doctor-patient relationship. We frequently hear patients saying that an XYZ doctor speaks so nicely that half of the pain is gone just by speaking with him. Or a particular doctor is so nice that just he touched me and my pain is reduced. In contrast, sometimes if the doctor don't speak nicely, the pain will increase and patient will say, I don't want to go to that doctor. He is so rude that my headache increases just by seeing him. So that's how the pain perception is altered by biopsychosocial variables. That's all about the pain perception. Now, before discussing about pain modulation, let's briefly discuss about the various neurotransmitters and endogenous opioids which control the pain transmission and thereby its perception. So, A delta fiber, they release glutamate, whereas C fibers, they release substance P and glutamate at the area where they form synapse in the dorsal horn of spinal cord. Neuronal cell bodies and axon terminals containing enkephalin and dynorphin are found in the dorsal horn of spinal cord, particularly in laminae 1 and 2, as well as in the rostral ventral medulla and the periaqueductal gray matter or PAG. Then the neurons that synthesize beta endorphin, they are confined primarily to the hypothalamus and their axons terminate in the periaqueductal gray region and on noradrenergic neurons in the brainstem. Next come to nucleus raphe which is located in rostroventral medulla and contains serotonergic neurons. The axons of these neurons, they project to the spinal cord and release serotonin in dorsal horn lamina 1, 2 and 5. Finally, the locus ceruleus. It is located in pons and contain noradrenergic neurons whose axons project to the spinal cord and release norepinephrine in the lamina 1 and 5 of dorsal horn. Now, with this knowledge in mind, let's begin our discussion on pain modulation. So, pain modulation can be better explained by the gate control theory, which was first explained by Melzack and Wall in 1965. Then in 1968, 3 years after the introduction of gate control theory, Ronald Melzack concluded that pain is a multi-dimensional complex with numerous sensory, affective, cognitive and evaluative components. According to this theory, the pain can be modulated by one or both of these two mechanisms. They are ascending pain modulation or ascending pain suppression system, and another is descending pain modulation or descending pain suppression system. So first, let's discuss about ascending pain modulation. So the ascending mechanism of gate control theory, it is based on increasing non-nociceptive input from the periphery into the spinal cord to elicit pain relief. This theory holds that the stimulation of receptors of A alpha or A beta fibers, which are carrying non-painful stimulus, can decrease the input of nociceptive stimuli from continuing to the second order neuron, thereby closing the gate for nociceptive impulses. This mechanism occurs in the dorsal horn of the spinal cord, specifically in lamina 2, which is also known as substantia gelatinosa. So A alpha and A beta fibers, they synapse on inhibitory interneuron in substantia gelatinosa while passing upwards through the spinal cord. So when the A alpha and A beta fibers are carrying non-nociceptive impulses, they facilitate this inhibitory interneuron, which in turn release enkephalin, thereby inhibiting secondary neurons which are carrying nociceptive impulses and thus closing the gate for nociceptive impulses. We call this ascending pain suppression system because the non-nociceptive impulses, while ascending upwards, they stop the nociceptive transmission. For example, if someone slaps you or someone pinches you, you immediately start rubbing the area, thereby stimulating the A alpha and A beta fibers, which then closes the gate for nociceptive impulses at substantia gelatinosa, and thus you feel relief of the pain. Application of gentle massage or applying pressure or vibration at the painful area also reduces the pain by this same mechanism. Now try to recall the memory of your school days, where if you forget to do homework and teachers hit you on the hand with a stick and you immediately start shaking your hand. Now you know the reason. This shaking stimulates mechanoreceptors, thereby stimulating A alpha and A beta fibers, which then closes the gate and the pain reduces. Now let's come to descending pain modulation. While the ascending mechanism formed the entire original gate theory, researchers concluded that the initial theory was incomplete, as it could not explain all the examples of pain control. Because pain is a complex interaction of physiological and psychological components, the role of the brain's ability to elicit pain control was recognized and included. The gate control theory was updated to include higher centers with the addition of cognitive control and descending inhibitory control. With the descending mechanism for pain control, it is important to acknowledge that the small diameter nociceptive pathway and stimuli are transmitting to higher centers. The influence of stimulating non-nociceptive large diameter afferents is not a part of these mechanisms. I repeat, stimulation of nociceptive fibers, that is A delta and C fibers, forms the basis for descending pain suppression system. And here there is no involvement of non-nociceptive impulses passing through A alpha and A beta fibers. The A delta and C fibers, they form synapse with inhibitory interneuron in substantia gelatinosa before synapsing with secondary nociceptive neuron. By these synapses, these A delta and C fibers inhibit the inhibitory interneuron, thereby indirectly facilitating the secondary nociceptive neuron, by releasing them from inhibition. And they also stimulate the secondary nociceptive neuron directly by synapsing with them. So if we stimulate the A delta and C fibers, the overall net effect is opening the gate at substantia gelatinosa and passage of nociceptive impulses upwards towards the brainstem. Now, while passing upwards, these nociceptive impulses, they stimulate periaqueductal grey matter or PAG in the midbrain. The neurons from PAG projects their axons to locus ceruleus and nucleus raphe in brainstem. And when the nuclei of PAG are stimulated, they in turn facilitates these two group of nuclei, that is locus ceruleus and nucleus raphe. These two nuclei indeed project their axons to the substantia gelatinosa of spinal cord, where they directly inhibit secondary nociceptive neurons and indirectly inhibit them by facilitating inhibitory interneurons, thereby closing the gate for nociceptive impulses and thus reducing the pain. It is important to note here that the neurons from locus ceruleus, they release norepinephrine, and those from nucleus raphe, they release serotonin. We are calling this mechanism of pain modulation as descending pain suppression system because the descending impulses from PAG, locus ceruleus and nucleus raphe closes the gate at substantia gelatinosa of spinal cord. For example, rubbing the lineaments at the site of pain reduces the pain by this mechanism. Then applying cold and heat reduces the pain by this mechanism, as pain and temperature uses common pathway. Application of TENS and acupuncture also reduces the pain by this same mechanism, as these stimuli are considered noxious and uses the same pathway as the pain. So that's all about the descending pain modulation. Next, come to central analgesia. Truly speaking, this is also a part of descending pain suppression system, but I am discussing it separately as more higher centers like limbic system, hypothalamus and other higher cortical areas are involved in this mechanism. We all know that pain is a complex perception that involves many cortical areas whose activity is influenced critically by the context in which the noxious stimulus is presented, as well as it is influenced by an individual's prior experience. Now, as said earlier, here the portions of cerebral cortex responsible for emotion, like limbic system, facilitate the periaqueductal gray region, thus starting a descending pain control mechanism. Prolonged pain and fear, they are the most powerful activators of this endogenous opioid-mediated modulating system. The same system is probably operative under a variety of other stressful conditions. For example, soldiers wounded in the battle, they require little or no analgesic medication. This is called as stress-induced analgesia. This example we have already discussed earlier in psychological variable of biopsychosocial model of pain perception. Another example of central analgesia is patients getting relief in their pain just by speaking with a particular doctor. The important opioid substances and neurotransmitters which are released for central analgesia, they are endorphins, dynorphins, enkephalins, serotonin and norepinephrine. So that's all for today. In next lecture, I will discuss about pain management. So keep watching. Thank you. Have a nice day.